and also the timing of surgery and all. And we know that now most of the congenital heart diseases are those who in which the surgery is indicated because of our Hridayam program. Surgical interventions are done appropriately at an early age. So the practitioners will be seeing more of children who already had cardiac surgery than those who are suffering from it. So in this context, we are having a talk on congenital heart disease, which will be helpful for both the general practitioners and practicing pediatricians. And today's talk is by Dr. Amitos Singh Baidwan. I'm not sure whether I have pronounced the name correctly.
Correctly, sir.
Okay, thank you. So he's a senior specialist in pediatric cardiology. He had his MBBS from Kathmandu University. Then he had a DNB in pediatrics and then FNB in pediatric cardiology. And he has attained specialized training in advanced interventional management of complex heart ailments in children. And his areas of special interest include fetal cardiology, fetal echo, and management of fetal cardiac arrhythmias. Now, we are seeing a lot of cases of congenital heart diseases diagnosed prenatally, and we have to take decision whether to continue their pregnancy or whether to terminate. So that decision also is becoming very important nowadays. So it's an authority to talk on such aspects also. So I would like to welcome all who has gathered here for this program, and also I welcome Dr. Amitos Singh Baidwan for his talk. Sir.
Can you see my screen?
Yes, sir. Sir,
I hope I'm audible.
You're audible, sir. It should be made as full screen.
Yeah, I'll make it that.
Okay, sir.
Okay.
Yes, sir. Perfect.
Yeah. All right. Shall I start, sir?
Please, sir.
Okay. Good evening, everyone. Right, sir. Good evening, everyone. I'm Dr. Amitos. I'm a senior specialist in Department of Pediatric Cardiology at Aster Medcity. So it's very nice to be with my, in the work, when I talk with my pediatrician friends, I still enjoy more talking with my pediatric people rather than a cardiology group. So we'll talk about today about congenital heart diseases in our day-to-day practice. What are the most commonest heart diseases which come to our OPD in our day-to-day practice, and what we should be guiding to the patients based on the reports of the echo which has been done, whether it has been done by a pediatric cardiologist or any other cardiologist, if it is reliable. So then how a general practitioner, pediatrician should approach to that case. Because previously there were a lot of myths about these shunt lesions that it will close. So we will address which one of the area, which shunt lesions will close on its own, and what is the natural history of a particular disease. I will try to cover it up. So if we overall see about among the congenital defects in the children, whether it is neonates or children with the cardiac defects are the most commonest among them, this group. and incidence is about 6 to 8 per thousand live birth. And this change in incidence is not happening much. It's over all over the world. It is almost the same. Even with the only thing is now the natural history is changing to a great extent, because with the advent of fetal echocardiography, we are picking up certain cases. In the West, there has been found that where the termination rate is less, there's no difference in the incidence rate. But however, if a lot of termination starts happening, then of course it might alter the incidence also with the advent of fetal echocardiography. And so even if the infants, around 10% of the infants' deaths are because of congenital heart diseases, majority of them are mild only, 85% of them are mild. It's only about 15% in the neonatal group, which are found to be life-threatening, which requires an early neonatal interventions. Overall, also, if you see the scenario among the congenital heart defects, it is the most commonest is the we see is the ventricle septal defect, which is around 39%, and followed by ASDs, then PDAs, and among the cyanotic group, we have the transposition of tetralogy, and rest of them, TGA, tricuspid, they're almost quite same. And so the spectrum to the acyanotic and cyanotic heart diseases. So we still have, what do we see in the day-to-day OPD practice is that it is the VSD is the most common for the ASD and the PA. And among the cyanotic group, it is the tetralogy group, which is the most commonest. Hope my voice is not lagging. Otherwise, I'll close my video. Is my voice clear, audible, or should I switch off my video? This paper was also published in the Archives of Disease in 2008, which was especially the involving group. So they studied a vast majority of them, 4,444 neonates, and they had about 669 had a life-threatening event. And about 8% of them only were diagnosed prenatally, and 62% of them were diagnosed postnatally before discharge from the hospital, and 25% of them were still discharged after discharge. And among those which were not discharged and not diagnosed, among them the most commonest was the coarctation of aorta, interrupted aortic arch, aortic valve stenosis, or TAPVC. So still if we see it, we tend to miss quite a number of cases even in the Western world at that time. But although now this article is quite late, but still coarctation and this TAPVC is among them is quite missed. But so especially when the ductus begins to close quite late, we tend to them. So coming to the VSD, which is the most commonest among the acyanotic heart diseases. So overall, we see ventricle septal defect. The most commonest among them is the perimembranous defect, followed by the muscular, and then we have the outlet VSDs, which is the subaortic VSDs, or what we have the subpulmonic VSDs. So basically, it depends, as it is depicting in this cartoon also. Based on where the location is of the defect, we have there have been a classification of the VSDs into different. So basically, the most commonest which we see is the perimembranous. Then we have the muscular. Musculars can further be classified as interior, posterior, apical, mid-musculars. So this classification is there, and this is this one, the subarterial group is also very important to understand, because this is the one which is not going to close on its own. So this, especially the subaortic and the subpulmonic one, which is the most important. So how do they present to us? As we all know that if it, most of them like small, based on what it depends upon how much is the type of the shunt is, whether it is a small shunt or a moderate shunt or a large shunt. So if it is a small shunt, the most of them would be asymptomatic, but later on, even this group of VSDs who do not close might develop an AR, and this AR, aortic regurgitation, keeps on progressing if it is not managed at an appropriate time. And moderate to large, usually the children are normal at around 6 to when PVRI is high. After that, they might have a dyspnea, failure to thrive, or they may be having suck rest cycles, sweating, recurrent chest infections, infective endocarditis. And if especially the larger ones, if we are not treating it at an surgically managing or closing them early, they will become child who is symptomatic, become asymptomatic, and then develop cyanosis. That is what we have is going into ischemic syndrome. So what is the natural history if we see is about 75 to 80%, 85% of the VSDs all closed. And this is true not only in the adult, once the child is born, but even if you see the fetal life also, majority of them will tend to close in the fetal life itself. When we see a VSD at around 18, 19 weeks of gestation and tend to evaluate them at around 32 weeks, we find a large number of VSDs, which even if they had a multiple VSDs, they tends to become smaller. And ultimately at birth, you might be finding a very small VSDs left behind. So VSDs is a one area which one should not be very much bothered about even in the antenatal time, that this is going to be a bothersome. So it is the large and the non-restrictive one, which is 10 to 15%, which are not going to close. And it is and especially I want to emphasize on the inlet VSDs and the outlet VSD, that is the subaortic and the subpulmonic VSD, or the doubly committed VSDs. They are the VSDs which will never close. Whether they are small, moderate, or large, we should be very clear that this is the VSD which is not going to close. And if the child is symptomatic, he has to be treated. So the location of the VSD is extremely important when we are analyzing a report which comes to us, that where is the location is, right? And the size of it based on the shunt quantification, whether the QP is to QS is more than 2:1 or 1.5 is to 2 in moderate, and a small it will be less than 1.5. But at the same time, we should analyze the patient as a whole also. How is the patient? Is my patient showing some features of evidence of failure to thrive or not? It will help us in clinically decision making, whether what we have to intervene or not. And even if we see this rate of spontaneous closure, around majority of them close in the first year of life, and then it begins to flatten out. So based on this knowledge, I just wanted to show this. So this is a subaortic type of large subaortic VSD. You can see this is a echo of a 3-month-old child, and you can see a large shunt going from left. This is the left ventricle, this is the right ventricle, and you can see a large shunt going out. So this child is 3 months old, 3.8 kgs, has a difficulty in breathing, suck rest cycle, features of cardiac failure were present. So in this, the decision making is very simple, that it has to be closed. This VSD will not close on its own because it's a subaortic VSD, number one, and it is definitely a large VSD. So that's why he's having evidence of congestive cardiac failure, and these are which are not going to respond to drugs. So this patient needs to be intervened early. Even at 3 months of age, we need to close this VSD. Otherwise, he will keep on having recurrent chest infection and land up in pneumonia and might die of pneumonia rather than of any other cause. On the contrary, if you see this is a 7 years old age. Same is also a VSD, and he is asymptomatic. Now, if you see this on the extreme right-hand side, this video, there is nothing in it except that if you see, the left ventricle is absolutely normal, right ventricle is absolutely normal, except the aorta is open. There's a mild ARS started to develop in this VSD, and it is typically located in the near the pulmonic area. It is a subpulmonic or a doubly committed type of VSD, as there is aorto and pulmonary continuity, and the VSD size is very small. So child has So this is the group of children. We know that this will not close on its own, and he is asymptomatic. Now the parents will ask you, sir, he's absolutely been fine. Why do we want to, you are suggesting it to operate? The answer is very simple, that he has started to develop aortic regurgitation. So once aortic regurgitation has developed, not to treat it now, even if it is a smaller VSD, if it will keep on progressing, the aortic regurgitation will keep on to more, and we all know that aortic regurgitation disease and such. So it becomes entirely an indication that it needs to be closed. If the C is small and is asymptomatic, and then we should keep on following this 2 months to 1 year, yearly follow-up to see much early. So if we see as per the guidelines, also we need to see annually every 1 year till 10 years of yearly, and close if AR or infective endocarditis episode is developing. Moderate VSDs, asymptomatic closure, they should be closed by 2 to 5 years. Symptomatic, controlled with medication between 1 to 2 years. Large VSDs, which are uncontrolled CCF, as soon as possible if it is controlled by 6 months. So these are the typical our IAP guidelines. Also, as we even in published in Annals of Pediatric Cardiology, these are absolutely Indian guidelines which have been published. But overall, one should always look at the clinically. If the child is showing failure to thrive, CCF is there, one should send the child early also. So these are the guidelines help us to these another in our as per the types based on the location where they. It could be an ostium secundum, it could be a sinus venosus ASD, it could be an ostium primum ASD. So it's the same. That is mostly of them, and most ASD in the future most of them will remain asymptomatic, except one who has a very large ASD might become symptomatic even less than 1 year of age. So if we see the natural history of the ASDs, closure rate, around 7 to 8 mm, those who are between 7 to 8 mm, majority of them will close. And this was a study which was done in 101 which was found that with the mean age of diagnosis around 26 days and average follow-up around till 9 months. So spontaneous closure, less than 3 mm, almost 100% will close. And around 3 to 5 mm, 87% had closed, and 5 to 8 mm, 80% have closed. But more than 8 mm, it is very unlikely that the ASD will also close. And second group of ASDs, one are those with sinus venosus ASDs and ostium primum ASDs, whether it is an IVC type or an SVC type, IVC type, and this is an SVC type ASD. These are also then ASD which will not close on its own. It is will require management at an age. And so if you see this is a 3-year-old child who had come to me with an ASD and diagnosed as otherwise he was absolutely asymptomatic, but it's RV and RA, you see it has dilated and there's a large intraatrial septal defect. You can see here also in the bicaval view, this is the SVC, this is the left atrium, this is the right atrium, and this is the ASD. And you can see a large shunt happening through it. And ultimately, so we decided that we have to go for a device closure, which was done later on. So this is a 2-year-old child who had come to me with an sinus venosus ASD. You can see this is again that view which is showing the SVC, and this is the left atrium, this is the right atrium, and this is the defect. This is near the SVC. So it is a typical sinus venosus ASD. It is 2-year-old child. Since he's asymptomatic, we can keep on waiting. And we can do it closure at around 4 years of age, which would be quite appropriate. That is before a child goes to school. We must tend to close it. But on the contrary, there are another group of children, such as this is an infant that who was admitted to us at day 12 of life. He was little dysmorphic. It was his short limbs. His nails were very hypoplastic, and his echo was showing to be having a common atrium. So it was an Ellis-Van Creveld syndrome. And so this is a group of ASDs, common atrium, but a very large atrium also, that they will develop failure much earlier, even less than 1 year of age. And these are the around 8 to 10% of the ASDs less than 1 year who have large ASDs might require a closure also. Although we keep on thinking that that most of the ASDs we need to close it later on because they're going to remain asymptomatic. So we will close it after 2. Ideal age which is recommended is 2 to 4 years and 4 to 5 years, but asymptomatic. Even if it is less than, showing the features of that there's of evidence of failure to thrive is there, and or congestive failure is there, then we can close it even less than 1 year of age also. We not to wait about till 4 years or 5 years or 4 years if that we want to close it. So one can think about closure into early. So the clinical examination and follow-up and plotting the weight on the charts is very important, and it gives us a great clue in patients, especially with congenital heart diseases. Another normal connection between which is present in the fetal life, without which the fetus cannot survive, which connects the pulmonary artery with the descending aorta, and we see the majority of in the fetal majority of the blood is passing this. And after the birth, when the PO2 level increases, the duct to happen between 12 to 29 hours of age, and 90% by 48 hours and 10% by 72 hours. Not closure by 3 weeks happens. But this problem of P is problematic for us in preterm babies, but over is morphologically abnormal, then this can be in a term baby also be detected. And this is also a left to right shunt. We see the rate of spontaneous closure in term baby by 4th day is around 100%, and those who are less than 1,000 grams is just 21% by 4th day of life. So this is one, I mean, it's more prevalent in the preterm babies. So clinical features which would be depending upon the amount of shunt which is happening in the preterm in a baby, that is when the when we have given surfactant, and which leads to improvement of the oxygenation, so the pulmonary vascular resistance compliance resistance reduces, so child may become respiratory distress, ventilatory requirements increase, CO2 increases. There would be a murmur would be present, but initially it would be only the systolic murmur, not a continuous murmur. Tachycardia, bounding pulses, hyperactive would be there, and signs of health failure develops and in preterm as compared to a term baby, because the LV is less compliant, and you will find a picture of an RDS congested lung field would be there. So to diagnose ECO is gold standard to demonstrate the PDA tells about the size of the PDA of the ventricle, and also to diagnose hemodynamic significant PDA also, as it is echo can pick up the hemodynamic significant PDA around 1.8 days before the clinical findings. This was published in the European Journal of Echocardiography in 2011. So this is just an echo which is showing us the PDA, and depending upon what is the size, what is whether it is small, moderate, or large, and or in a preterm we should go by the kg. More than 1 mmHg kg is definitely a large PDA. And this is just by the flow patterns of the chart, we can see initially it is, so this is the group which is with growing PDA or a pulsatile PDA, which needs to be a closure is required. And so the guidelines are also, this is also left to right shunt. If it is a large PDA, it's not about in preterm babies I'm talking about, it's about the term baby also. If it is a large PDA with CCF, we must have to close it by 3 months of age, moderate size between 6 months, no CCS 6 months to 1 year. If failure to thrive is present much little early also. Small PDAs, we can wait till around 1 to 1.5 years of age, but those who are silent, we do not need to close it. So if it is only an audible murmur is there, only then we need to do something about these PDAs. Otherwise, we don't. Treatment is again conservative, pharmacological, and surgical. This is conservative management is just, this is a slide is showing about in the preterm babies management, but otherwise we have to give in diuretics and to give another one for preterm babies. What we can do is we should keep a hematocrit above 35%. We should do a slightly give a fluid restrictions, and it has been published Cochrane review also in 2008 that fluid restriction to 50 to 80 ml per kg per day reduces the risk of PDNEC in a preterm babies. And pharmacologically, there is no role of prophylactic therapy, but however, we need to we can give indomethacin, which is in a dose of 0.1 milligram per kg, 12 hours later, second dose, and IV infusion. But nowadays we are not using indomethacin. Most of them are using ibuprofen or now, which has come is the paracetamol. And this is a wonderful drug that there is very little side effects, and the rate of close is also very good. And it is 15 milligram per kg per 6 hourly for 5 days we can give. We can route is IV and oral and rectal also can be given, but still we are in our nursery, we are using IV as a drug of choice. And it has been found even recently in the published data, there is no difference between the rate of closure of PDA between indomethacin and paracetamol. It is found to be equally efficacious. And interventions nowadays can close it with the smaller devices. This is a device which was used for bigger babies. This is for preterm babies. Now another device which is called as a Piccolo device has been launched, which in India, which is you can close it in a 1 kg and above. Also, you can close with the device closure can be done. So this is just a angiogram which is just showing to you that this. So this is this in so. Which is demonstrating the patent tuberculosis filling the pulmonary, and through which we have passed the wire and the device we are passing, and finally, ultimately, it is you see the device we try to pull it back. And we get a tug out of it, and finally push it back, and we'll find the PD like this. And this is the device ultimately after releasing it. So surgically, if we close with 2 courses of pharmacotherapy, then we need to close with surgical. Very preterm baby, if the PD is very large and our devices we don't have is not suitable, then we can do surgically. It can be done in the NICU itself and just clipping it. So I take home conclusion that we should assess the child clinically. Evidence of failure to thrive or congestive, go for an early closure. So we should see the child not only by the guidelines and size of the shunts which we are quantifying by echo, we should stand whole. That's most important. The third one, coarctation of aorta. This is one disease which needs to be missed in the new, usually around day 5 or day 6 of life in a state of shock. So usually we'll find a child is absolutely, you have attended a delivery and he's absolutely fine, discharged home, and then after 5 days he comes to you that he's in a state of shock. You might find that there could be feeble pulses, but the difference between upper and lower limb pulses might not be there, because there would be because if the LV is severe, LV dysfunction is present, in that cases, you will not find a difference between an upper lower limb gradient more than 20. So that is there, but then it can be associated with certain syndromes, the Turner syndrome. This is a very important slide. One should always arterial pulses. That means both upper and lower limb pulses should be simultaneously felt, and even both be felt. This just diagram can have in the pulses. Normally, if the coarctation is here, you will find that's why we have an upper limb would be high pressure and low, and it would be different in the pulses there. But however, if it's an apparent right subclavian artery post ductus, then you will find that there's a reduced pulse on the right side and a normal pulse on the left side. Similarly, if it's the right air arch and an apparent left subclavian artery, you will find that the left pulse is reduced. So most of them are asymptomatic during evaluation for hypertension or epistaxis or dysphagia, which can be happening in aberrant right subclavians if it is aneurysmally dilated, and they can be lower limb differences, and S1 would be normal, S2 would be loud, ejection click would be present. And you can have another figure of three, inverted figure of three appearances would also be there, but in the neonatal period, you have only megaly and would be present. On a CT scan, we can easily make it out. Nowadays, we can do three-dimensional printing also, and before doing an intervention, we can do it. This is a case of a newborn which was came to me, and he was brought in a state of shock. All of them we were treating them in sepsis, but I did, the LV was not contracting at all. So when in a newborn, when I see that this baby in a LV is not contracting, I tend to go find two things. One is anomalous alcapa, that is the anomalous region of the left subclavian artery, and or the coarctation. And you will see there's a discrete shelf is present over here, and there's a post-stenotic dilatation is there, and hardly there is any flow coming through it. So this child was started on prostaglandin, and he was taken. What is the indication for intervention? If the quark gradient is more than 20, if there is LV dysfunction, then even less than 20 also becomes an indication. And or the child is hypertension with more than 50% narrowing, it is there. It is important for us to diagnose this coarctation much earlier, because if we tend to delay, one paper was published that we do not treat the quark. If we treat the quark till 1 year of age, the chances that his hypertension will be he will not require drugs to control hypertension. But as we move on after 1 year, the rate of control of hypertension, drugs is possible, but then he might be dependent on antihypertensives. So it's very important that we should close it. So ideal age of intervention would be LV failure, immediate. Normal LV function, no CHF, mild hypertension, we should do it at 3 to 6 months. Normal LV function, no CCF, no hypertension, 1 to 2 years of age is the one. Then quark with VSD, then both the defects has to be done in a single setting. Right, mode of intervention in the neonatal period, it is absolutely surgical. There is no choice, although some of they keep on saying that we can do stenting, we can do balloon. It is there, but still, I would say that as per the gold standard guidelines in a neonatal period is surgery. But however, if a child who has come a recoarctation after a surgery, we can do a balloon dilatation. Then or you can do in a 1-year-old child also, we can do a balloon dilatation. And later on, around 80 years of age or more than 25 kgs, we can undergo a stenting. So this was a patient who was brought to us with 17 years old child, came to us for evaluation of hypertension. And you can see there was an angiogram done. And you can see there's a coarctation area which is there. So they finally took him stenting of the you can see the balloon was dilated, and there is no quark, and we didn't have any gradient also. So follow-up in this group of patients has to be lifelong follow-up. It is not that we just leave them once it is that there is no quark, but you have to annually follow them, and then 2 to 3 yearly. And after 5 years of age, we should do a 3 to 5 MRI has to be done, because they also have a predisposition to develop aneurysms in the brain. One must do this cerebral angiogram must also be done in this group of patients. And the beta blockers are the preferred drug of choice for control hypertension and infective endocarditis has to prophylaxis to be given for first 6 months. So even in the even the asymptomatic heart diseases, whenever they're going either going surgical closure or a device closure, we need to give, if he has to undergo as per the AHA guidelines for infective endocarditis, there needs to be done for us first 6 months. After that, it is not required. The third set, one set is what we have is a single ventricle physiology. That means they don't have a two ventricles. So that means these are not going to be corrected, fully correctable. Then we have to undergo a palliation method. In this, the main thing which you have to assess is that whether he has a pulmonary stenosis or not, whether this is an increased pulmonary blood flow, reduced blood filtration. If it is a pulmonary, then we need to not to worry initially, and his saturations are 75%, then it's okay. And we have to just directly go for a bidirectional gland in which we anastomose pulmonary arteries, and then later on do a Fontan between 2 to 4 years. But if the pulmonary stenosis is mild, then we have to protect the lung bed from developing pulmonary hypertension, then do a pulmonary artery banding at around 6 to 8 weeks of life, and then do a glen at around 4 to 6 months of life, and later on do Fontan completion. So if you see, this is a echo of which is showing a large ventricle in which both DIL, this is a case of a DILV, in which both the valves are opening into a single chamber, and there's a hypoplastic right ventricle with a VSD is present into, and even in the Doppler flow, you can see both the mitral and the tricuspid and the mitral valves are opening into the same chamber, which is a smooth walled ventricle, which is of LV morphology. So it is a DA, and ultimately, and they have a good branch P. As you can see, there's a lot of turbulence. He had a patient this came to us around 6 years of age directly, but we thought since it is naturally it is his pulmonary blood flow is protected, we directly underwent this. Third, the patient come to you with arrhythmias, that is in the form of, if you see there is, heart rate is very slow, the ventricle rate is very slow, then form of complete heart block. You can see that when you have, the ventricle rate is, the RR interval is constant, but the ER interval keeps varying, then the diagnosis of a complete heart block is made. And the indication for a pacemaker in this group of disorders is with complete heart block, it is less than 55 without congenital heart diseases, less than 70 with congenital heart disease. More than 1 year, it is 50, and without congenital heart disease, less than 50 without congenital heart diseases, and less than 70 with congenital heart disease. Thank you. I am done. Hello, sir. I'm with you.
Hello.
Hello.
Yes.
I've completed. I hope I was audible, or
Yes, you are audible.
okay. I've completed my presentation.
Sir Mohandas, sir, the presentation have been over.
Okay. I would like to invite others for the comments. Hello, any doubts? Hello.
Sir, we have a question in the chat box.
Okay, please read. Sabi.
How to detect congenital heart disease and in Italy?
Yeah. See, now the congenital heart diseases can be detected antenatally by doing a fetal echocardiogram, and especially if it is in high risk pregnancy. If it is, that means if there's a positive family history of congenital heart disease is present among the family members, or antenatally when they do a anomaly scan, they found something is abnormal, then one must get a detailed fetal echo done by especially by a pediatric cardiologist, and to see and in this era, majority of the congenital heart defects, and like the left threatening, except for the ASDs and small BSDs and PDA, we cannot pick it up because that is already there. But 90% of them we can pick up them in the fetal life as early as we can do it at around 17 weeks of gestation, but ideal age is between 18 to 21 weeks of gestation. So we pick them up. If the others like hypoplastic left heart and can even pick up by doing a transvaginal ultrasound at around 12 weeks of pregnancy also.
Now, I think more and more people are getting trained in doing fetal echo, and I think there are few views suggested which has to be done for all cases, and if there are any confusion or a doubt, it has to be referred to a pediatric cardiologist for further evaluation.
Yeah, exactly. When now they've incorporated the 5-chamber view, that means the outlets also have to be seen. So with that, yes. The pickup rate of TGAs and other areas have tremendously increased.
I think we can identify which are the correctable ones and which are the things which are really difficult, and according to that we have to counsel
once we have diagnosed it, the approach is very simple. So once we have diagnosed it, we know that what is going to be the natural history, what is going to be the management of this patient, which patient will require an early neonatal intervention, which will not require an early neonatal intervention. We can rule out the genetic disorders also. That is part. Even if the patient is having an uncorrectable disease, might be going for a termination, but she must undergo an amniocentesis and microarray analysis must be done, so as to if there's a syndromic association, so that this can help in her subsequent pregnancy as well.
Any other doubts? Anyone can unmute and ask.
Sir.
Okay, so okay, sorry. So before I invite Dr. Sabik for the vote of thanks, I would like to mention two things. One is tomorrow and day after tomorrow we are having a conference on pediatric COVID. Tomorrow we will be having paper and poster presentations, and on Sunday we are having the actual conference. I would like to invite all for the same. And our Mother and Baby Friendly Hospital Initiative program is done with a lot of enthusiasm in our hospitals. We will have to declare the hospitals Mother and Baby Friendly in the coming week. So I think all should have a self-assessment as per the checklist and be ready for the inspection. So it was a nice talk, which abruptly ended. I thought that there will be more details coming. Anyway, I would like to invite
Okay.
Dr. Sabik for vote of thanks.
Good evening, all. So, it's a simple, very simple, understandable presentation. I was listening the whole presentation. Thank you. I would like to thank Dr. Amitosh Singh sir for this wonderful presentation. And also, I would like to thank all the participants who were participating in the event. And also, Mohandas sir and Dr. Ajay for attending the program. So, thank you. Thank you all. Good night. So, shall we stop?
Hello. Can we stop?
Yes.
Thank you, sir. Thank you very much for that nice talk.
Okay. Okay.
Thank you, sir.